Welcome to the deep dive. Today, we're really going deep, aiming for mastery on the pharmacology of sex hormones, specifically estrogens and progestins.
Right.
These are absolutely fundamental. We see them in hormone replacement, cancer therapy, and obviously contraception. So our mission today is for you, the listener, to get that complete, detailed picture. We're covering everything in our source material, like you're getting briefed by the top people in the field.
Exactly. This isn't just surface level. With hormones, the real understanding comes from knowing the nuances, how tiny changes affect everything, the risks, the benefits. That's the mastery level.
And to get there, we probably need a quick look back. Where did this all start? It wasn't actually that long ago, scientifically speaking.
No, it really gathered steam around 1900. That's when it was firmly established that, yes, the ovaries are releasing some kind of chemical signal controlling female function.
But knowing that and knowing what are two different things.
Totally different. The big step came in 1923. Allen and Doisy figured out a bioassay. They used an alcoholic extract from ovaries.
Okay.
And showed it could induce estrus, heat in spayed animals. Suddenly, they had a way to measure this stuff.
A measurable effect. That's key.
It's the starting point for everything else. And then, not long after, 1929, they nailed it.
They got the actual molecule.
Yes. Isolated estradiol in pure form, figured out its structure. That opened the door to synthesis, pharmaceuticals, everything we're discussing today.
Okay, let's dive into estrogens then. Section 1, synthesis, regulation, potency. The basic definition is pretty simple, right? Any substance causing estrus in spayed animals.
That's the technical definition. But in humans, we're really talking about three main players.
The natural trio.
Right. Estradiol, estrone, and estriol. And estradiol is, well, it's the main one. It's what the ovary secretes the most of.
Synthesized where exactly?
It's made from cholesterol in the Graafian follicle cells before ovulation, then the corpus luteum after, and the placenta goes wild with it during pregnancy. Its power comes from having the highest affinity for the estrogen receptor, the ER.
But it doesn't stick around long in its original form, does it? The liver gets involved quickly.
Very quickly. Estradiol gets rapidly oxidized in the liver, primarily into estrone. And then estrone can be hydroxylated further to become estriol.
Are estrone and estriol still active?
Oh yeah, they're active, they circulate, but their binding affinity for the receptor is much, much lower than estradiols, so less potent overall.
And it's not just a female hormone, which might surprise some people.
Not at all exclusive. Men produce estradiol too, maybe 2 to 20 micrograms a day. It's not coming straight from the testes in that form, though.
How does it happen then?
It's mostly through aromatization. Testosterone gets converted into estrogen, both in the testes and, importantly, in other tissues like fat cells, extraglandular conversion.
Interesting. The source also mentioned horses. Equilin.
Yeah, mares produce large amounts of equilin. It's another estrogen, chemically distinct, about a fifth as potent as estradiol. Just shows a diversity.
Let's talk regulation. The feedback loop. Daily secretion fluctuates wildly, 10 to 100 micrograms. That's a huge range.
It absolutely is, and it's all tied to the phase of the menstrual cycle. It's orchestrated by the hypothalamic pituitary-ovarian axis.
So walk us through that cycle influence.
Okay. FSH from the pituitary kicks things off in the follicular phase, stimulating the follicles to grow and produce more estrogen. Levels climb. Then, just before ovulation, there's this transient surge of FSH, and estrogen spikes again.
And after ovulation?
The corpus luteum takes over, pumping out estrogen, along with progesterone, until it degrades if pregnancy doesn't occur.
And how does estrogen signal back to the brain and pituitary to sort of dial things down?
It's negative feedback. Estrogen inhibits FSH secretion, and if the levels get high enough, it inhibits LH too.
Where does this inhibition happen?
It acts directly on the pituitary gland itself, but also higher up on the hypothalamus, influencing the release of GnRH, gonadotropin-releasing hormone. It adjusts the pulse frequency and amplitude.
Okay, that's the normal cycle. What about extreme states? Pregnancy, for instance.
Oh, pregnancy's a whole different league. The placenta just becomes this estrogen factory. We're talking up to 30 milligrams a day near term.
Milligrams? That's orders of magnitude higher.
Massive amounts, mostly estrone and estriol in that case. And then, bang, after delivery, levels plummet right back down.
And the opposite extreme, post-menopause.
Yeah, ovarian function pretty much ceases. Estrogen production drops dramatically down to maybe 2 to 10 micrograms a day. a tiny fraction.
Where does even that small amount come from if the ovaries are out?
It's almost all from that extraglandular aromatization we mentioned. Adrenal glands produce androgens, and tissues like fat convert those androgens into estrogen. So there's still a baseline, but it's very low.
This leads us right into the big pharmacological problem with natural estrogens. You can't just take an estradiol pill effectively.
Right. Because the liver is so efficient at breaking it down, that first pass metabolism just inactivates it almost completely if taken orally. Plus, its duration of action is naturally quite short.
So that's the driver for drug development.
Absolutely. Medicinal chemists had to get creative. They developed synthetic steroidal estrogens like ethinyl estradiol and even non-steroidal ones. The goal was always oral activity and longer duration.
How do they make the non-steroidal ones work? They don't look like steroids.
They had to mimic the shape. The key insight was that these non-steroidal compounds adopt a specific three-dimensional shape, a trans configuration that allows them to fit snugly into the estrogen receptor, just like the natural hormone. That mimicry is crucial for binding.
While being different enough chemically to survive the liver.
Exactly. Structural similarity for function, chemical difference for survival.
Okay, section 2. Estrogen actions, mechanism, metabolic impacts. Let's unpack what estrogens actually do. Puberty is the obvious starting point.
Right. Estrogen drives the growth of the whole female reproductive tract, uterus, fallopian tubes, vagina.
What changes in the vagina specifically?
The lining, the epithelium gets thicker, it stratifies, becomes cornified, but the really critical action is on the uterus, on the endometrium.
The proliferative phase.
Yes. Estrogen builds up that thick cellular endometrial layer before ovulation. This estrogen priming is absolutely essential. Without it, progesterone can't do its job later to induce the secretory changes needed for potential implantation.
We need to clarify how menstruation is triggered. It's not always the same mechanism, is it?
No, it depends. In a normal ovulatory cycle, it's the withdrawal of progesterone from the dying corpus luteum that triggers bleeding. But if ovulation doesn't happen in an ovulatory cycle, there's no corpus luteum, no progesterone surge.
So then what triggers it?
In that case, it's simply the decline and withdrawal of estrogen itself that causes the bleeding. And interestingly, the source notes you can't stop normal progesterone withdrawal bleeding even with high doses of estrogen.
Estrogen also affects muscle contractions and secretions, right?
Yeah, it increases the rhythmic contractions of the fallopian tubes and the uterus. It also makes the uterus more sensitive to oxytocin. And in the cervix, it induces that characteristic fertile, mucus, watery, alkaline, profuse, perfect for sperm to get through.
And the secondary sexual characteristics.
That's estrogen too. Breast development stimulating the ducts and stroma, fat deposition, maintaining those feminine body contours, and interestingly, it helps suppress acne.
How does it do that? Acne seems like an androgen thing.
It often is linked to the small amounts of androgens produced around puberty. Estrogen, especially in pharmacological doses like in contraceptives, suppresses the whole pituitary gonadal axis, including that androgen production, which helps acne regress.
Let's get into the deeper metabolic effects, anabolic action.
Estrogens do have some anabolic effect, building tissue, but it's much weaker than testosterones. They contribute to that growth spurt at puberty.
But they also stop growth eventually.
Yes, crucially, they promote the fusion of the epiphyses, the growth plates in long bones in both males and females. That's what ultimately limits final adult height.
Okay, the big one. Bone health. This is critical.
Absolutely critical. Estrogen is essential for maintaining bone mass, and it does this primarily by slowing down bone resorption. It inhibits the osteoclasts, the cells that break down bone.
How does it inhibit them? Does it kill them?
Not directly kill them. It inhibits the formation of the little pits they dig into the bone surface. It also boosts the osteoblasts, the bone-building cells, making them produce more matrix proteins like osteonectin, osteocalcin, collagen, and alkaline phosphatase.
And the mechanism involves the estrogen receptors on these bone cells.
Yes, both osteoblasts and osteoclasts have ERs, but the main action seems to be indirect. Estrogen modifies the signals, the cytokines that osteoblasts send out, and these signals then tell the osteoclasts to mature less and be less active. It's a sophisticated communication system.
Anything else related to minerals? Calcium?
Yeah, it promotes a positive calcium balance. Part of that is by inducing the enzyme in the kidney needed to make the active form of vitamin D3.
Okay, moving through other metabolic areas. Fluid balance. Glucose.
Estrogen can cause a bit of salt and water retention, potentially leading to edema, especially at higher doses. Glucose is interesting. The older high-dose combined pills did impair glucose tolerance, increasing diabetes risk.
But not the modern ones.
Generally, no. The lower doses used in current HRT and contraceptives seem to have minimal effect on carbohydrate metabolism for most people.
Lipids. This is where estrogen really shines, cardiovascularly speaking.
It's a major benefit. Estrogens decrease LDL, the bad cholesterol, and they increase HDL, the good cholesterol, and also triglycerides. That favorable shift in the HDL-LDL ratio is thought to be a key reason why premenopausal women have much lower rates of atherosclerosis.
But here comes the trade-off. Coagulation.
The flip side, this is the big risk, especially with oral estrogen. It increases blood coagulability by telling the liver to produce more of certain clotting factors, specifically factors 2, 7, Ni, X, and X.
Does it affect the clot-busting system too?
It does. It actually increases fibrinolytic activity by lowering PAI1, but the net effect, unfortunately, is still procoagulant. Increased risk of clots, VTE.
What about effects on blood vessels themselves?
Potentially beneficial there. Estrogens induce nitric oxide synthase and PGI2 production, which are vasodilators. Helps relax blood vessels.
And other liver effects. Bile. Binding proteins.
Yeah, liver effects are significant. Estrogen makes bile more lithogenic, more prone to forming gallstones by increasing cholesterol secretion into bile and reducing bile salt secretion. And it ramps up liver production of various binding globulins.
Like SHBG, TBG, CBG.
Exactly. Sex hormone binding globulin, thyroxine binding globulin, corticosteroid binding globulin. Their levels go up, but usually the amount of free active hormone doesn't change much, so the overall hormonal status isn't really altered by this.
Let's pin down the mechanism of action. It's all about the nuclear receptor, right?
Primarily, yes. Estrogens diffuse into target cells found in sex organs, breast, liver, bone, CNS, blood vessels, lots of places, and bind to specific estrogen receptors, ERs, inside the nucleus.
What happens after binding?
Binding causes the receptor to change shape and form a pair, a dimer. This dimer then binds to specific DNA sequences called estrogen response elements, or EREs.
And it turns genes on.
It recruits other proteins called coactivators, and this whole complex then promotes the transcription of target genes. That's the classic genomic mechanism.
How do antagonists, like antiestrogens, work then?
They bind to the same receptor, but they cause it to adopt a different shape. This altered conformation doesn't recruit coactivators. Instead, it recruits core pressors.
And core pressors shut genes down.
Exactly. They actively inhibit transcription. So the same receptor, but a different ligand shape, leads to the opposite effect. That's the basis for SERMs, too.
And there isn't just one estrogen receptor.
No, there are two main types, ER alpha and ER beta. Their distribution varies. ER alpha is the main one in the uterus, vagina, breast, bone, blood vessels. ER beta is more predominant in the prostate and ovaries.
Does estradiol bind differently to them?
Natural estradiol binds pretty equally to both, but synthetic drugs, especially the SERMs, can show different affinities, or more importantly, they interact differently with the co-regulator proteins present in different tissues, leading to tissue-specific effects.
And some effects are much faster than gene transcription allows.
Right, the non-genomic actions. These seem to be mediated by ERs located in the cell membrane, not the nucleus. They can trigger rapid signaling cascades. We see this in granulosa cells, for instance.
Okay, section 3. Estrogen pharmacology and HRT. We know natural estradiol is tough orally, but it's absorbed other ways.
Yeah, well absorbed transdermally, through the skin via patches or by injection. But orally, that first-pass metabolism is the killer.
Remind us of the metabolism pathway.
Estradiol gets converted to estrone and estriol, then conjugated, usually with glucuronic acid or sulfate, to make it water-soluble for excretion in urine and bile. And there's that enterohepatic circulation.
Well, it gets reabsorbed from the gut.
Exactly. The conjugates get broken down by gut bacteria. The estrogen gets reabsorbed, goes back to the liver. It extends the exposure time.
But ethinyl estradiol beats the system.
Right. That ethanol group at position 17 chemically protects it from rapid breakdown in the liver. That gives it a much longer half-life, 12 to 24 hours, makes it orally active and significantly more potent than natural estradiol.
The dose differences are really striking. Like 0.1 milligram parenteral estradiol equals 10 milligram conjugated estrogens.
Huge difference. It really highlights that bioavailability challenge. And the fact that oral and parenteral doses of ethinyl estradiol are almost the same tells you it completely bypasses that first-pass problem.
Which brings us to transdermal patches, estradiol TTS. What's the big advantage?
Avoiding the liver flood. When you take an oral estrogen pill, the liver sees a really high concentration first. This stimulates it to make lots of proteins, including those clotting factors we talked about, and the binding globulins and angiotensinogen.
And the patch avoids that initial surge.
Yes. By delivering estrogen slowly through the skin, you get more stable blood levels, and you don't hit the liver with that high peak concentration. This means less stimulation of clotting factors, binding globulins, angiotensinogen.
Lower risk of clots. That sounds like a clear win.
It is a significant advantage in terms of thromboembolic risk. The usual patch dose, maybe 0.05 milligray a day, mimics the natural levels seen in the premenopausal follicular phase.
But there's always a trade-off, isn't there? What's the downside?
The downside is you lose some of the beneficial liver effects. Specifically, the improvement in the lipid profile raising HDL, lowering LDL, isn't as pronounced with transdermal estrogen compared to oral.
Why not?
Because that beneficial lipid effect is a direct consequence of the oral estrogen interacting with the liver during that first pass. So bypass the liver, reduce clot risk, but also reduce the lipid benefit.
Let's catalog the adverse effects of estrogens. Systemic, dose-dependent. What about in men?
Prolonged use in men leads to suppression of libido, gynecomastia, breast development, and general feminization.
And in children?
The big risk is premature fusion of the epiphyses, the bone growth plates. This leads to a shorter final adult height.
In postmenopausal women, if given alone?
Without a progestin to oppose it, estrogen significantly increases the risk of endometrial cancer, like 5 to 15 times higher. And irregular bleeding is very common.
What about breast cancer? It's complicated.
Very. Estrogen can definitely make existing ER-positive breast cancers grow faster, but the data suggests that low-dose, estrogen-only HRT probably doesn't increase the risk of developing a new breast cancer. That's an important distinction.
Other risks?
Doubled risk of gallstones, a higher risk of benign liver tumors, especially in younger women on high doses historically. It can worsen migraines, epilepsy, endometriosis, and absolutely contraindicated in pregnancy.
Okay, hormone replacement therapy, HRT.
Yeah.
Why was it used so widely? What problems of menopause does it address?
It addresses a whole constellation of issues. The immediate ones are vasomotor symptoms, hot flashes, night sweats, and urogenital atrophy, vaginal dryness, pain with intercourse, recurrent UTIs.
And longer-term issues.
Osteoporosis, the loss of bone mass leading to fractures, skin changes like thinning and wrinkling, and then psychological or cognitive issues like mood swings or memory problems, plus the increased risk of cardiovascular disease after menopause.
And HRT is effective for many of these.
Highly effective, especially for the vasomotor symptoms, the psychological disturbances, preventing the atrophy, and definitely for preventing osteoporosis.
But everything changed with the big clinical trials like HERS and the Women's Health Initiative, the WHI.
Those trials, particularly WHI, really shifted the landscape. They studied older women, many starting HRT years after menopause, and found significant risks.
So what's the current thinking, the consensus?
Much more restrictive. HRT is now generally recommended only for managing moderate to severe menopausal symptoms, using the lowest effective dose for the shortest possible duration. And ideally starting it relatively soon after menopause begins, generally before age 60 or within 10 years of the final period.
What are the typical regimens? Lower dose than contraception?
Yes, much lower. For example, conjugated estrogens at 0.625 milladreba or even less. And critically, if the woman still has her uterus, a progestin must be added for at least 10-12 days each month.
Why the progestin?
To protect the endometrium. The estrogen alone causes the lining to proliferate, increasing cancer risk. The progestin counteracts that, causing secretory changes and preventing hyperplasia or cancer. If she's had a hysterectomy, estrogen alone is fine.
Let's revisit the HERS and WHI findings on cardiovascular risk. They were quite alarming.
They were, especially in the older women studied, combined HRT, estrogen plus progestin, significantly increased the risk of VTE, venous thromboembolism, by about 3 times. It also increased the risk of stroke, and particularly in the first year, myocardial infarction, MI.
Was it the estrogen or the progestin causing the heart issues?
The data pointed towards the progestin, at least for coronary artery disease. The estrogen-only arm of WHI in women without a uterus didn't show that increased MI risk.
But there's nuance now, the timing hypothesis.
Right. Later analyses suggest that starting HRT earlier, closer to menopause, say within 10 years and before age 60, might actually be protective against MI. The risk seems to emerge when HRT is started much later in women who already have underlying atherosclerosis. Timing appears critical.
What about brain health? The WIMS study.
The Women's Health Initiative memory study, WIMS, was also disappointing. In the older women they studied, age 65-79, HRT didn't protect against cognitive decline. In fact, it actually doubled the risk of developing dementia, including Alzheimer's.
Let's summarize the cancer risks, because it's a real balancing act.
It is. Combined HRT, estrogen plus progestin, was shown to significantly increase the incidence of breast cancer. Again, the progestin seems to be the main driver there.
But estrogen alone increases endometrial cancer risk.
Exactly. So you need the progestin to protect the uterus, but that same progestin might increase breast cancer risk. It's a difficult trade-off.
And osteoporosis. HRT used to be the go-to.
Not anymore. While it absolutely works, it restores positive calcium balance, slows bone loss. It's no longer considered first-line treatment solely for osteoporosis prevention or management.
What's preferred now?
Bisphosphonates are generally preferred. They're more targeted for bone and don't carry the same systemic hormonal risks as HRT. HRT isn't usually recommended just for bones beyond 5 years or in women over 60.
Briefly, what about tibolone? Is it a better option?
Tibolone is interesting. It's a synthetic steroid that breaks down into metabolites with estrogenic, progestational, and weak androgenic actions. It helps symptoms in osteoporosis without stimulating the endometrium, which is good.
But it hasn't really taken off.
Not widely, no. Its long-term risk-benefit profile isn't as well defined as standard HRT, and maybe the androgenic component causes side effects. It just hasn't gained major traction.
And quickly, other, more niche uses for estrogens.
Yeah, topical estrogen is great for senile vaginitis, keeps the effect local. Cyclic estrogen progestin can be used to induce puberty in cases of delay, sometimes used for severe dysmenorrhea by suppressing ovulation, adjuvant in dysfunctional uterine bleeding, and palliatively in prostate cancer to suppress androgens.
Okay, moving to section 4, drugs that fight estrogen, antiestrogens, SERMs, and aromatase inhibitors. Let's start with the classic, clomiphene.
Clomiphene citrate. It's a nonsteroidal drug related to tamoxifen. It works by blocking estrogen receptors, specifically in the hypothalamus and pituitary.
So it makes the brain think estrogen is low.
Exactly. It blocks that negative feedback. So the pituitary responds by pumping out more gonadotropins. FSH and LH pulses increase significantly.
Which stimulates the ovaries.
Forces them into action. Stimulates follicles to develop, hopefully leading to ovulation. That's its main use. Inducing ovulation in women who aren't ovulating to treat infertility.
What are the downsides?
Because it's an antiestrogen peripherally, hot flashes are common. Also risks like ovarian hyperstimulation leading to cysts, a higher chance of multiple births, twins, etc., and maybe a long-term risk of ovarian tumors with prolonged use.
Now for the really sophisticated players.
Yeah.
Selective estrogen receptor modulators, SERMs. These are fascinating.
They really are. They bind to the ER, but depending on the tissue and the specific SERM, they can act as either an agonist or an antagonist. It's all about the final shape the receptor takes and which co-regulator proteins it interacts with in that specific tissue.
Tamoxifen is the prototype SERM. What's its profile?
Tamoxifen is a potent antagonist in breast cancer cells and blood vessels, but it acts as a partial agonist in the uterus, bone, liver, and pituitary.
That mixed profile dictates its use.
Absolutely. It's the standard hormonal treatment for ER-positive breast cancer, both after surgery, adjuvant, and for advanced disease, palliative. And it's the only drug approved for preventing breast cancer in high-risk premenopausal women, cuts incidence by about 45%.
And treatment duration has been extended.
Yes, that's a major update. The ATLS and ATOM trials showed that continuing adjuvant tamoxifen for 10 years instead of the traditional 5 provides further benefit in reducing recurrence and improving survival.
But that uterine agonist activity is a problem.
It is. Tamoxifen stimulates the endometrium, which increases the risk of developing endometrial cancer. And, like estrogen, it increases the risk of deep vein thrombosis, VTE, by about 2 to 3 times.
Then there's raloxifene, designed to be different.
Raloxifene has a different pattern. It's still a partial agonist in bone and on lipid metabolism, which is good, but critically it's an antagonist in both the endometrium and the breast.
So no increased uterine cancer risk with raloxifene.
Correct. That's a major advantage over tamoxifen.
What's raloxifene used for?
Primarily 2 things. Second-line option for preventing and treating osteoporosis. It cuts vertebral fracture risk significantly, though maybe not as much as bisphosphonates. And it's also approved for preventing breast cancer in high-risk postmenopausal women, reducing risk by about 65% for ER-positive cases.
Does it help with menopausal symptoms?
No, it doesn't. In fact, because it's an antagonist peripherally, it can actually cause hot flashes, similar to clomiphene. And importantly, it still carries that same 3-fold increased risk of VTE and pulmonary embolism as tamoxifen.
Beyond SERMs, we have pure antagonists, the SERDs. Fulvestrant,
SERDs, selective estrogen receptor down-regulators. Fulvestrant is the main one. If SERMs are like tricky keys that turn the lock differently, fulvestrant is like breaking the lock.
How does it work?
It's a pure antagonist. It binds the ER, stops it from dimerizing, prevents it from binding DNA, and it targets the receptor itself for degradation by the cell. It actively gets rid of the receptor.
Down regulation.
Exactly. That makes it very effective for ER-positive breast cancer that's become resistant to tamoxifen or for advanced disease.
Finally, in this category, the aromatase inhibitors, AIs. These block estrogen production itself.
Right. AIs are a cornerstone therapy, but almost exclusively in postmenopausal women. They inhibit the aromatase enzyme, which is the enzyme responsible for the final step in estrogen synthesis, converting androgens into estrogens.
Where does this conversion happen postmenopausally?
Mostly in peripheral tissues like fat, muscle, and also within the breast tumor itself. AIs block this, leading to almost complete estrogen deprivation in postmenopausal women.
There are different types of AIs.
Two main classes. Type 2 inhibitors like letrozole and anastrozole are nonsteroidal and bind reversibly. Type 1 inhibitors like exemestane are steroidal, bind irreversibly, and act as suicide substrates. They permanently disable the enzyme molecule they bind to.
And their use is first line now in postmenopausal breast cancer.
Yes, for ER-positive disease, they are often first line, both in the adjuvant setting after surgery and for metastatic disease. They've generally proven more effective than tamoxifen in delaying recurrence and improving survival in this population.
Why only postmenopausal generally?
Because in premenopausal women, the ovaries are still the main source of estrogen, driven by FSH and LH. If you use an AI, the low estrogen will signal the pituitary to pump out tons more FSH and LH, which would just overwhelm the AI and potentially cause ovarian hyperstimulation. You can use AIs premenopausally, but only if you also suppress ovarian function, usually with a GnRH agonist.
Let's really zero in on the comparison. AIs versus tamoxifen in postmenopausal women. This is crucial clinical detail.
Absolutely. Key differences in side effects. AIs cause significant bone loss, increasing fracture risk, and often cause joint pain or arthralgia. Why? Because they wipe out nearly all estrogen, including its protective effect on bone.
Tamoxifen doesn't do that.
No, because tamoxifen is a partial agonist on bone, it actually helps preserve bone density. That's a major difference.
What about clots and lipids?
Here, AIs have the advantage. They do not increase the risk of VTE, and they don't have much effect on the lipid profile. Tamoxifen, as we said, increases VTE risk, but has beneficial effects on lipids. So it's a completely different risk-benefit calculation depending on the patient's profile, bone health versus clot risk.
Fascinating. Okay, section 5, progestins. The progestational hormones. Definition.
Substances that can take an estrogen-primed endometrium and convert it to the secretory phase, ready for implantation, and that help maintain a pregnancy. Think pro-pregnancy. Natural progesterone was isolated around the same time as estradiol, 1929.
Where does natural progesterone come from?
Mainly the corpus luteum after ovulation, about 10-20 milligray day. If pregnancy occurs, the placenta takes over and makes huge amounts in the second and third trimesters. Men produce a little from adrenals and testes, maybe 1 to 5 milligray day.
What about taking it as a drug? Is it like a SERDs?
Very similar problem. Natural progesterone is almost completely inactive orally because of massive first-pass liver metabolism, and its plasma half-life is incredibly short, like 5 to 7 minutes. It's cleared very rapidly, metabolized mainly to pregnanidyl conjugates for excretion.
So how do we give it effectively?
Micronization helps. Grinding it into very fine particles and suspending it in oil in a capsule allows some absorption through the lymphatic system, partially bypassing the liver. That gives some oral activity. But mostly we rely on synthetic progestins.
And the synthetics fall into two main chemical families.
Right. Based on their carbon structure. First, you have the progesterone derivatives, which still have 21 carbons like progesterone itself. Medroxyprogesterone acetate, MPA, is a common example.
What are they like?
They tend to be purer progestins, meaning they have mostly progestational activity without much androgenic or estrogenic baggage. They generally have weaker anti-ovulatory effects compared to the other class.
So what are they used for?
Because they're less disruptive to the cycle, they're often preferred for HRT, providing that endometrial protection, or for treating conditions like endometriosis, where you want the progestin effect without necessarily stopping ovulation completely.
And the second class? The more potent ones.
Those are the 19-nortestosterone derivatives. They're derived from testosterone and are missing a carbon atom at position 19, so they only have 18 carbons, estrogens, or sometimes a modified 18-carbon structure, gamanus.
And these are the workhorses in birth control pills.
Exactly. They have much more potent anti-ovulatory action. The older ones, the estrogens like norethindrone, unfortunately, still carry some baggage, weak estrogenic, androgenic, and anabolic effects.
Which led to newer generations.
Yes. The gonanes, like norethindrone and its active isomer 11-argestrol, were developed. They have an ethyl group at position 13. They're more potent progestins and have reduced androgenic activity compared to the earlier ones.
And even newer ones, third generation.
Right, like desogestrel, gestadine, norgestimate. These are even more potent. Gestadine inhibits ovulation at tiny doses, like 40 micrograms. And crucially, they have very little or virtually no androgenic activity.
Why is that lack of androgenicity important?
It makes them much better choices for women who might have issues with androgens, like acne or hirsutism. And importantly, they don't counteract the beneficial effects of the estrogen component in birth control pills on the lipid profile.
Let's detail the actions of progesterone itself. What does it do in the uterus?
Its main job is to act on the estrogen-primed endometrium. It induces secretory changes, the glands become tortuous, secrete glycogen, the tissue becomes more vascularized, getting ready for an embryo.
And if pregnancy occurs?
Continued progesterone makes the endometrium decidualize, decreases the contractility of the uterine muscle, and makes it less sensitive to oxytocin. All crucial for maintaining the pregnancy. If levels drop, menstruation occurs.
What about the cervix?
Opposite effect to estrogen. Progesterone makes the cervical mucus thick, viscous, scanty, and cellular. This hostile mucus forms a barrier to sperm penetration.
And the breast.
It works with estrogen to develop the breast further, specifically causing proliferation of the acini, the milk-producing glands, getting things ready for potential lactation.
Does progesterone affect the brain?
Yes. Higher concentrations can have a mild sedative effect. It can influence mood, sometimes contributing to PMS symptoms, and the key thermogenic effect.
The temperature rise.
Exactly. Progesterone resets the hypothalamic thermostat slightly higher, causing that characteristic 0.5 degrees Celsius rise in basal body temperature after ovulation, a reliable marker that ovulation has occurred.
Metabolic effects. Lipids are key here again, especially with the synthetics.
Big difference between progestin types. The more potent, more androgenic 19-nortestosterone derivatives, like levonorgestrel, tend to have unfavorable effects on lipids. They can raise LDL and lower HDL.
Counteracting the estrogen benefit.
Potentially, yes. This might contribute to atherogenesis risk with long-term use of certain pills. However, micronized natural progesterone doesn't seem to have these adverse lipid effects. Some progestins might also slightly impair glucose tolerance.
And the feedback effect on the pituitary.
Progesterone itself is a relatively weak inhibitor of gonadotropin secretion. Its main effect seems to be reducing the frequency of GnRH pulses from the hypothalamus, but it works synergistically with estrogen together. They powerfully suppress gonadotropin release, especially the LH surge, which is key to the anti-ovulatory effect of combined pills.
What about adverse effects of progestins?
Common things can include breast tenderness or engorgement, headache, maybe some edema, or mood swings. Acne can be an issue with the more androgenic types.
Yeah.
Irregular bleeding or even amenorrhea can happen, especially with continuous use like in minipills or implants.
And the serious warnings.
That potential for atherogenesis with the 19-nor derivatives due to lipid changes. And the big one, contraindication in early pregnancy. Exposure of a female fetus, especially to the older androgenic progestins, could potentially cause masculinization.
Okay, therapeutic uses.
Mm-hmm.
We mentioned HRT and dysfunctional uterine bleeding. What else?
Endometriosis is a major one. Continuous high-dose progestin creates a pseudopregnancy state, low estrogen, no ovulation, which causes the ectopic endometrial tissue to atrophy and regress.
Other uses.
Sometimes used for severe premenstrual syndrome, PMS. Again, using high doses to suppress the cycle. Historically used for threatened or habitual abortion, but only if a true progesterone deficiency is proven, and you'd want a pure progestin without androgenic effects. Also used palliatively for advanced endometrial cancer.
Section 6. Specialized agents in contraception systems. Let's talk danazol first. It's a weird one.
Danazol is definitely unique. It's chemically derived from ethisterone, a synthetic progestin. It has a mix of weak activities, androgenic, anabolic, progestational, even glucocorticoid.
So what's its main action? How does it work?
Its primary effect is suppressing gonadotropin secretion from the pituitary. This shuts down ovarian function, and testicular function in men. It also has direct effects, inhibiting steroid-producing enzymes in the gonads, though not aromatase.
Used mainly for endometriosis.
That was its main indication. It creates a hypoestrogenic and novulatory state that shrinks endometrial implants, effective in maybe 75% of cases, but its use has really declined.
Why? Side effects.
Significant androgenic side effects are common and often limiting. Acne, oily skin, weight gain, hirsutism, deepening of the voice, which can be irreversible, edema, muscle cramps, also potential liver issues, just too many problems compared to newer options like GnRH agonists for endometriosis.
What else was it used for?
Sometimes second line for menorrhagia, heavy periods, fibrocystic breast disease, and interestingly for hereditary angioneurotic edema because it boosts levels of C1 esterase inhibitor.
Okay, moving to antiprogestins and progesterone receptor modulators, PRMs. Mifepristone, RU486, is the big one here.
Mifepristone is a potent antagonist at the progesterone receptor. It also has significant anti-glucocorticoid activity, which is relevant for some other uses.
How does it work for terminating pregnancy?
It blocks progesterone's effects on the endometrium. This prevents the maintenance of the uterine lining, causes detachment, and importantly, it sensitizes the uterus to prostaglandins and stimulates uterine contractions, leading to expulsion.
Usually used with a prostaglandin.
Yes. The standard medical abortion regimen is a dose of mifepristone followed 1-2 days later by a prostaglandin, like misoprostol. This combination is highly effective, over 90% success, for pregnancies up to about 7 to 9 weeks, depending on the protocol.
Other uses for mifepristone.
It can be used for cervical ripening before surgical procedures. It's effective as emergency postcoital contraception, investigated for once-a-month contraception. And because of its anti-glucocorticoid effect, it can be used palliatively in high doses for Cushing's syndrome.
What about ulipristal? It's specifically for emergency contraception.
Ulipristal acetate is a selective progesterone receptor modulator, an SPRM. It acts mainly by delaying or inhibiting ovulation. It suppresses the LH surge needed for follicular rupture.
How does it compare to levonorgestrel for emergency use?
Its main advantage is a longer window of efficacy. Both work well up to 72 hours, but ulipristal seems to maintain better effectiveness when taken later, between 72 and 120 hours, 3 to 5 days, after unprotected intercourse.
Okay, let's organize all this into hormonal contraceptives, OCs. The combined pill is the most common.
Right. The combined oral contraceptive, COC, usually contains a synthetic estrogen, typically ethinylestradiol, maybe 20-35 micrograms, and a synthetic progestin, one of the 19 NOR derivatives. Taken for 21 days, then a 7-day break for withdrawal bleeding. Hugely effective.
What about phased pills?
Phased or multiphasic pills vary the dose of the progestin and sometimes the estrogen across the 21 days, trying to mimic the natural cycle more closely and potentially reduce the total hormone dose per cycle. Efficacy is similar to fixed-dose pills.
Then there's the progestin-only pill, the POP, or minipill.
Yes, this eliminates the estrogen component entirely, which avoids estrogen-related risks like VTE. It contains just a small dose of progestin taken continuously every single day without a break.
Is it as effective?
Slightly lower efficacy than combined pills, maybe 96-98% effective with perfect use, closer to 91% with typical use. Ovulation isn't consistently suppressed in all users, so it relies more heavily on other mechanisms.
Like what? We need to cover the mechanisms of action. Let's use table 22.3 from the source as a guide. Primary mechanism of the combined pill.
The number one mechanism for COCs is inhibition of ovulation. The combination powerfully suppresses gonadotropin release from the pituitary.
How does each component contribute?
The progestin primarily suppresses LH, reducing pulse frequency and abolishing the mid-cycle surge needed for ovulation. The estrogen suppresses FSH release, which prevents follicular development. Together, they provide strong synergistic inhibition. No follicle matures, no egg is released.
Okay, that's the main mechanism for combined pills. What about the mini pill, where ovulation might still happen? What are the secondary mechanisms?
The key secondary mechanism, active in all progestin-containing methods, combined pills, POPs, implants, injectables, is the change in cervical mucus. The progestin makes it thick, viscous, and impenetrable to sperm, a physical barrier.
And tertiary mechanisms, especially important for POPs and emergency contraception.
This involves changes to the endometrium itself. The progestin makes the lining unreceptive to implantation. It might be thin, atrophic, or out of phase with where it should be if an egg were fertilized. So even if fertilization somehow occurred, implantation would likely fail. This is probably the most important backup for POPs.
Any other effects?
Possibly alterations in the motility of the uterus and fallopian tubes, making transport of sperm or the egg less efficient.
Let's not forget the long-acting methods. Injections, implants.
Right. Depot medroxyprogesterone acetate, DMPA, is a common injection given every 3 months. Norethindrone enanthate, NEE, is another, given every 2 months, highly effective. Implants, like Nexplanon, etonogestrel, or older ones like Norplant, levonorgestrel, are small rods inserted under the skin, releasing progestin slowly for years, for e.g. 3 years from Nexplanon. There are also progestin-releasing IUDs, like Mirena.
What are the practical points? Fertility return, missed pills.
Fertility usually returns pretty quickly after stopping oral pills, often within 1 to 2 cycles. But return can be significantly delayed after stopping DMPA injections, sometimes taking many months, even over a year. For missed combined pills, there are specific protocols depending on how many are missed, and when in the cycle usually involves taking the missed pill ASAP and using backup contraception for 7 days. If pregnancy occurs while on OCs, termination is usually advised due to potential risks.
We should mention raloxifene, Centroman. Again, here, the Indian SERM used for contraception.
Right. It's nonsteroidal, acts mainly as an estrogen antagonist in the uterus and breast. Its contraceptive effect isn't fully blocking ovulation, but seems to be due to creating asynchrony between the embryo and the uterine lining, preventing implantation, usually taken once or twice a week. Doesn't typically stop periods, but can make cycles irregular or longer. Also used for dysfunctional uterine bleeding.
Okay, Section 7. Contraception risks, contraindications, and those unique non-contraceptive benefits. Let's start with adverse effects, the minor transient ones.
Common in the first few cycles. Nausea, maybe some vomiting, mild headache, breast tenderness or fullness, maybe some breakthrough bleeding or spotting, especially with progestin-only methods or very low-dose pills. These often settle down.
What about effects that might appear later or persist?
Weight gain is reported by some women, though studies are mixed. Acne can be triggered or worsened by the older, more androgenic progestins. Chloasma, that patchy skin pigmentation, can occur. High-dose pills could impair carbohydrate tolerance. Mood swings or depression can happen in susceptible individuals.
Now the serious stuff, primarily linked to the estrogen, right? VTE risk.
Venous thromboembolism is the most significant serious risk, though the absolute risk with modern low-dose pills is still low, maybe 2 to 3 cases per 10,000 women per year. Not 1,000, as I misspoke earlier, important correction. But that baseline risk is significantly increased by other factors.
What factors really increase that VTE risk?
Age over 35 is a big one, especially combined with smoking. Obesity, diabetes, hypertension, personal or family history of clots, prolonged immobilization, like after surgery. These multiply the risk considerably. The risk does return to baseline fairly quickly after stopping the pill.
What about arterial clots, heart attack, stroke?
There's a small increase in the risk of MI and stroke even with low-dose pills, but again, this risk is massively amplified by other cardiovascular risk factors like smoking, hypertension, diabetes, and age.
Hypertension itself. Can the pill cause high blood pressure?
It can. Maybe 5–10% of women on older, higher-dose pills experienced a rise in BP. It's less frequent and usually milder with modern pills. It seems related to estrogen increasing angiotensinogen production by the liver. If BP rises significantly, the pill should be stopped. It usually normalizes.
Cancer risk. This is always a major concern. What's the overall picture?
It's complex, but somewhat reassuring for some cancers. Overall, OC use doesn't seem to increase the risk of cervical or liver cancer in the general population.
What about protective effects?
Big protective effect against both endometrial cancer and ovarian cancer. This is thought to be due to the progestin component counteracting estrogen on the endometrium and the general suppression of ovulation reducing ovarian cancer risk. The protection lasts for years after stopping.
Breast cancer.
This is the most debated. Large studies suggest a very small increase in the risk of being diagnosed with breast cancer while currently using OCs or shortly after stopping. However, this risk seems to disappear within about 10 years after stopping, and the cancers diagnosed may be less aggressive. Overall, for young women, this marginal increase is generally considered very small compared to the benefits.
Other risks. Liver, gallbladder.
Slightly higher incidence of benign liver tumors, hepatic adenomas, which are rare but can rupture, and a slightly increased risk of gallstones, likely due to estrogen's effect on bile composition.
Given these risks, what are the absolute contraindications? When should combined pills definitely not be used?
Red flags. Any history of VTE, DVT, or PE, stroke, coronary artery disease, or other arterial thrombosis. moderate to severe hypertension, active liver disease or liver tumors, known or suspected breast cancer or other estrogen-dependent cancer, undiagnosed abnormal vaginal bleeding, porphyria, and planned major surgery requires stopping the pill about 4 weeks beforehand. Smoking over age 35 is often considered an absolute contraindication too.
And relative contraindications, where you need to be very cautious.
These include well-controlled mild hypertension, diabetes, especially with vascular complications, obesity, smoking under age 35, migraine headaches, especially with aura, history of cholestasis during pregnancy, requires careful risk-benefit assessment.
Drug interactions leading to contraceptive failure. Big issue. What drugs are culprits?
2 main mechanisms. First, liver enzyme inducers, drugs like rifampicin for TB, certain anti-epileptics, phenytoin, carbamazepine, barbiturates, St. John's wort. They speed up the metabolism of both the estrogen and progestin in the pill, lowering blood levels and potentially leading to failure. Need backup contraception.
And the second mechanism?
Antibiotics that disrupt gut flora, drugs like tetracyclines, ampicillin. By killing gut bacteria, they can interfere with the enterohepatic circulation of estrogen. Remember how conjugates are broken down and reabsorbed. If that's interrupted, estrogen levels can fall. The evidence here is a bit more controversial than for enzyme inducers, but caution is often advised.
But it's not all risk. OCs have significant non-contraceptive health benefits too.
Absolutely. We mentioned the big ones. Lower risk of ovarian and endometrial cancer.
Wow.
Also, reduce menstrual blood loss, which means less iron deficiency anemia. Regularization of cycles, which is great for women with irregular periods. Often significant improvement in PMS symptoms, dysmenorrhea, period pain, and menorrhagia, heavy bleeding.
And benefits for benign conditions.
Yes, reduced incidence and relief from benign fibrocystic breast disease, and fewer functional ovarian cysts because ovulation is suppressed. For many women, these benefits are a major reason for choosing OCs.
Okay, last point. The challenge of male contraception. Why is it so difficult? We've had the female pill for over 60 years.
It's fundamentally harder for several reasons. Biology is the main one. You need to stop the production of millions of sperm every day versus stopping the release of just 1 egg per month. That requires near complete suppression.
And sperm production takes time.
Yes, spermatogenesis takes about 64 days, so there's a long lag time before any drug would become effective, and also a long time for effects to wear off makes it clinically awkward.
But the biggest hurdle is side effects, right?
Unacceptable side effects have plagued every approach tried so far. To effectively stop sperm production, you generally need to suppress gonadotropins, FSH and LH. But suppressing LH also suppresses testosterone production by the testes,
Leading to?
loss of libido, impotence, fatigue, mood changes, loss of muscle mass, bone density loss. Basically, chemical castration. Totally unacceptable. Trying to add back just enough testosterone to prevent side effects while still suppressing sperm is incredibly difficult to balance.
What about other approaches?
Antiandrogens also cause libido loss. Estrogens or progestins cause feminization. GnRH analogs cause impotence unless testosterone is added back perfectly. Cytotoxic drugs are too toxic systemically. Gossipol from cottonseed showed promise by directly affecting sperm development without hitting libido, but it caused irreversible infertility in some men and serious systemic toxicity, including potentially fatal hypokalemia leading to paralysis.
So still no viable options.
None that are safe, effective, reversible, and acceptable. The biological bar is just much higher, the side effect profile is prohibitive, and perhaps historically there's been less societal and commercial drive compared to female contraception. It remains a major unmet need.
Okay, this has been incredibly detailed. We've really covered the spectrum from basic synthesis to the complex pharmacology of SERMs, AIs, progestins, and the practicalities of contraception and HRT.
Yeah, the key is seeing the connections, how receptor subtypes like ER-alpha and beta allow for tissue selectivity with SERMs, how AIs achieve near total estrogen blockade, the constant balancing act in HRT.
Especially that progestin paradox in HRT, and pills needed for endometrial safety, but potentially adding risk elsewhere, like the breast or cardiovascular system.
It really underscores that these are powerful agents. As the consensus now emphasizes, their use requires deep individualization. You can't just prescribe them routinely. Age, time since menopause, personal risk factors, they all have to be weighed.
So the final thought for our listeners. We've gone from the discovery of estradiol in the 1920s to drugs that can selectively downregulate specific receptors. We have immense scientific knowledge now.
But the application of that knowledge is still very much an art. It requires constant clinical judgment, adapting to new evidence from trials, understanding the patient in front of you. The provocative thought might be, does this incredible precision we now have actually make the decisions harder because we're forced to confront these complex risk-benefit trade-offs in every single patient? We can't just say hormones are good or hormones are bad anymore. It's always for whom and when. That's the real challenge of mastery in this field.